Hi, this is Dr. Perry Carpenter. I'd like to thank you for taking the time to join me on this week's video. On this week's video, we're continuing with our ongoing series entitled Permanent Impairment Home Runs and Strikeouts. And today begins session 2 of this program. And just a quick review, in session 1, we talked about the philosophy of Alvarez and Guzman and how the law considers the strict application of the AMA guides to be prima facie evidence of the correctness of the examinee's permanent impairment level. So the philosophy of Alvarez and Guzman basically states that if you're going to provide a rebuttal position to rebut the AMA guides and to rebut the law, which again states that the strict application of the AMA guides is prima facie evidence of the correctness of the impairment rating, if you're going to rebut those two prodigious authorities, your opinion on the alternative impairment rating, your rebuttal opinion that is, must qualify as substantial medical evidence. And as regards Alvarez and Guzman alternative impairment ratings, the threshold or the standard of substantial medical evidence is fairly tall. It's not an insurmountable threshold. It's not a threshold that cannot be surmounted, and the AMA guides certainly can be rebutted. But if you're going to rebut the AMA guides, it has to be done properly. It has to be done according to the dictates of case law, which I'll share with you again in today's discussion. And the opinion must constitute substantial medical evidence. Now, this is critical with regards to alternative impairment ratings under Alvarez and Guzman, because typically, and this applies to 100% of the cases that I've had a chance to review, but typically alternative impairment ratings under Alvarez and Guzman have the result or have the impact of increasing the permanent impairment rating. I've never once seen a single alternative impairment rating under Alvarez and Guzman that resulted in a lower permanent impairment rating. Well, the Alvarez and Guzman line of cases admonish us as evaluating physicians from using alternative impairment ratings simply to achieve a better result. And that's a phrase that's described in the Alvarez and Guzman line of cases. We are not to go on a fishing expedition through the guides, or we are not to manipulate the guides simply for the purpose of achieving a better result. And in this instance and in these circumstances, a better result simply means a higher permanent impairment rating. So your permanent impairment ratings, your alternative permanent impairment ratings under Alvarez and Guzman will, in 100% of the cases, result in a higher permanent impairment rating. Well, of course, this is going to draw great scrutiny from the defense attorney and from the claims administrator. So your opinion on an alternative impairment rating must be solid. It must be substantial medical evidence. And in our last discussion, we concluded our last discussion by emphasizing that only alternative impairment ratings that are actually true, that are actually truly more accurate than the impairment rating under the strict application of the guides, only those impairment ratings will be upheld. Only true and only accurate ratings will be upheld. And this is where the threshold of substantial medical evidence lays to waste many otherwise would be good alternative impairment ratings under Alvarez and Guzman, because these would-be other alternative impairment ratings fail to survive the truth filters and fail to qualify as substantial medical evidence. Now, in today's discussion, I want to continue along with the same philosophy and share with you and show you how to qualify your opinions as substantial medical evidence by following the exact formula that we described in our last session. And today I want to focus on one particular aspect of alternative impairment ratings under Alvarez and Guzman, and that has to do with what's known as the direct estimate method of rating for permanent impairment. And today, we'll review the direct estimate method as relates to the spine, as relates to the upper and the lower extremities. And I want to share with you 3 cases that illustrate the use of the direct estimate method of rating permanent impairment. 2 of those cases held opinions that the trier of fact, whether that be the workers' compensation judge or the workers' compensation appeals board, failed to find the opinion as substantial medical evidence. And then one case represented a true home run where the alternative impairment rating was upheld by the trier of fact, and the alternative impairment rating had the impact or the significance of increasing an otherwise fairly generous permanent impairment rating of 29% whole person impairment, all the way up to 45% whole person impairment, more than a 50% increase in the permanent impairment rating. So this is substantial because it added 16 percentage points from 29 to 45, 16 percentage points of additional impairment simply by resorting to an alternative impairment rating under Alvarez and Guzman. So I have 3 fascinating cases to share with you today, all of which illustrate the direct estimate method of rating permanent impairment. Okay, so let's talk about the direct estimate method of rating permanent impairment first, as relates to the spine. Okay, so if you're going to use the direct estimate method of rating permanent impairment related to spine injuries, related to upper extremity injuries, related to lower extremity injuries, doesn't matter the type of injury. But when you're using the direct estimate method or any other alternative impairment rating method under Alvarez and Guzman, you must follow the 4-step formula if you hope to have your opinion qualify as substantial medical evidence. Now, in the examples that we're going to go over in today's discussion, you're going to see variable uses of these 4 different procedures in establishing the opinion as substantial medical evidence. Now, opinions that incorporate all 4 of these steps, of course, qualify as substantial medical evidence and have a greater likelihood of being upheld by the trier of fact, including only 1 or only 2 or only 3 of the criteria, of course, would reduce the likelihood of the opinion qualifying as substantial, and further providing weak explanations and weak reasonings in these procedural steps will diminish the likelihood of the opinion being qualified as substantial. So to review, let's go over the 4-step magical formula to have your opinion accepted as substantial in providing for alternative impairment ratings. So step number 1, and not too many people, not too many evaluators have any difficulty with this step, and that involves providing a strict rating under the AMA guides. Now, your strict rating under the AMA guides, whether you're providing an alternative impairment rating or not, must in and of itself qualify as substantial medical evidence. In other words, it must be based on an adequate history and examination. It must not be speculative. It must be based on pertinent facts. And all of those criteria under Escobedo that qualify an opinion as substantial medical evidence, all of those apply here to step number 1. Now, once you've done that, then you can proceed with step number 2, which is to explain why the strict rating does not accurately reflect applicant's disability. And you must support your reasoning why with multiple voluminous and compelling reasons. Now, of those 2 adjectives, voluminous and compelling, compelling is the more important. The reasons must be compelling
but also, in addition to compelling reasons, the more voluminous reasons you have to support your opinion as to why the strict rating does not accurately reflect the applicant's disability, the more substantial will be your opinion. Then step number 3 is to provide an alternative rating using the 4 corners of the AMA guides. And again, this is an area where few evaluators have any difficulty. This is quite an easy thing to do. But again, this opinion must qualify as substantial medical evidence. It must be based on pertinent facts. It must be based on an adequate examination and history. It must not be speculative or based on guess, surmise, or conjecture. And all of those criteria under Escobedo also apply to this opinion. And then finally, you must explain why the alternative rating most accurately reflects the applicant's level of disability much more accurately than the rating which is found under the strict application of the guides. And again, you must support your reasoning with multiple voluminous and compelling reasons. Now, these are the areas that represent the difficulties, explaining why. This is the challenge facing doctors who desire to use alternative impairment ratings, is in supporting their opinions with voluminous and compelling reasons. And there's an art and a science to this, and that is the basis of today's discussion. Now, the direct estimate method of rating spinal impairment is based largely on figure 19 of the AMA guides. And what figure 19 of the AMA guides shows us is it shows us the whole spine. If we read here below the footnote of the figure, it says the whole spine is divided into regions indicating the maximum whole person impairment represented by a total impairment of one region of the spine. So when the lumbar spine is 100% impaired and a person has 100% loss of function of the lumbar spine, that represents a 90% whole person impairment. When the thoracic spine is 100% impaired, there's a complete loss of function of the thoracic spine, that represents a 40% whole person impairment, and the cervical spine represents an 80% whole person impairment when it's 100% impaired. Now, there appears to be some confusion when using the direct estimate method of rating permanent impairment, and I'll share with you some of those confusions here as we illustrate our 3 cases, and I'll summarize the confusions by giving you what appears to be sage advice if you elect to employ the direct estimate method in your next spine injury case. Some of the confusion seems to exist between an apparent contradiction between the text associated with the figure that we just reviewed. I think it was figure 1519, figure 1519, and the text that accompanies that section of the AMA guides. So let's review the text and see if we can unravel some of this confusion. So this section of the AMA guides is entitled Converting. This is the criteria for converting whole person impairment to a regional spine impairment. And it says, in some instances, the evaluator may be asked to express an impairment rating in terms of the involved spine region rather than the whole person. So I can tell you that in my career, I've never been asked this. I've never been asked this. In California, the permanent disability rating schedule relies on whole person impairment rating values. So I've never been asked to express a whole person impairment value in terms of a regional spine impairment. But this is the text as it's described. This would be similar to taking a whole person impairment for an upper extremity injury and describing it as an upper extremity impairment, for example. We don't typically do that here in California. We take upper extremity impairment values and convert them to whole person impairment values. So in my opinion, this is the source of some of the confusion of using this method as relates to spine injuries. Well, it says this is done, in other words, converting whole person impairment to regional spine impairment is done by dividing the whole person impairment estimate by the percent of spine function that has been assigned to that region. And we just saw figure 1519 that assigned certain percentages of function to the spine. Under the DRE method, a whole person estimate being converted to a regional estimate would be divided by 0.35 for the cervical spine, 0.20 for the thoracic spine, and 0.75 for the lumbar and sacral spine. Under the range of motion method, and it seems that figure 1519 is more based and exemplary of the range of motion method, a whole person estimate being converted to a regional estimate should be divided by 0.8 for the cervical spine, 0.4 for the thoracic spine, or 0.9 for the lumbosacral spine, referencing figure 1519. So they give us an example. A 24-year-old female office worker sustained a cervical injury that, after it was healed and stable, resulted in a whole body or whole person impairment estimated by the DRE method of 20% whole person impairment. So this is a significant cervical spine injury. Dividing 20% by 0.35 under the DRE method results in 50% impairment of the cervical spine. So that's 50% cervical spine impairment, similar to expressing upper extremity impairments in terms of upper extremity impairment versus whole person impairment. As another example, an individual with multiple lumbar compression fractures was rated 25% whole person impairment by the range of motion method. To obtain an estimate of lumbar spine impairment, the physician should divide 25% by 0.9, resulting in 27.7% rounded up to 28% lumbar spine impairment. Any values that exceed 100% are rounded down to 100% regional impairment. So according to section 1513 of the AMA guides, figure 1519 is to be used in converting whole person impairments to regional spine impairments. It's similar to table 16.3, wherein we convert upper extremity impairments to whole person impairments. Well, in this case, we're sort of working in reverse by taking a whole person impairment rating and breaking it down and describing it as a regional spine impairment. But the confusion over this rating method seems to involve the footnote, which tells a slightly different tale. And what this footnote here seems to describe is that when a person has a 100% loss of function of the lumbar spine, that equals a 90% whole person impairment, 40% for the thoracic and cervical, 80%. So the philosophy of the direct estimate method of rating involves an estimation by the evaluating physician as to the actual percent loss of function of the lumbar spine, and then multiplying that loss of function by the maximum impairment value associated with that region of the spine to come up with a whole person impairment rating specific to that percent of loss of function. So for example, in the cervical spine, if you as the evaluating physician determined that the examinee had lost 50% of the function of the cervical spine, we would take 50%, multiply that by 80%, which is the maximum value of the cervical spine, to come up with 40% whole person impairment. 40% is 50% of 80%. Similarly, 50% of loss of function of the lumbar spine would be 50% times 90%, which would be 45% whole person impairment. So that's how figure 1519 is used in rating spinal impairments. The only challenge for you as the physician in using this rating method would be in supporting your percentage of loss of function of the spine. So for example, if you opine that examinee has lost 50% of the function of the lumbar spine, how do you support that specific percentage of loss of function? It's, in my opinion, it represents quite a challenge, and your reasonings better be good. They better be based on facts. They better be based on an adequate exam. They better be based on voluminous facts, and I'm not exactly sure how you could do that. So let me give you an example. If a person lost 100% of function of the lumbar spine, what type of symptoms and what types of losses of activities of daily living would you expect to see in that particular examinee? This would be an examinee who had absolutely no function of the lower extremities, absolutely no function of the bowels and bladder. And this is an examinee who's in pretty rough shape, 100% loss of function of the lumbar spine. It would seem to me that a person who has 100% loss of function of the cervical spine, through which the entire spinal cord passes, through which all the upper extremity spinal nerve roots pass, it seems to me that that examinee would be in worse condition than a person with 100% loss of the lumbar spine. And perhaps Christopher Reeves could be an example of an examinee who has 100% loss of function of the cervical spine. So supporting your opinion on percent of loss of function of the region of the spine is going to be your challenge. And we'll review 3 cases to illustrate how different evaluators either successfully or unsuccessfully did this. With regards to the direct estimate method related to the upper extremities, these estimates are based on figure 16.2 related to amputations at various levels. So for example, when an examinee has an amputation of the upper extremity just below the head of the humerus, that represents a 100% loss of function of the upper extremity. And that makes sense because there's no upper extremity left to function. An examinee who has an amputation just below the elbow has a 95% upper extremity impairment, and an examinee who has an amputation just below the level of the wrist has a 90% upper extremity impairment. And these convert to 60% whole person, 57% whole person, and 54% whole person. So to use the direct estimate method for upper extremity impairments, you as the evaluator would simply estimate the percent of loss of function of the examinee's upper extremity and then multiply that percent loss of function by the whole person impairment maximum value to come up with your alternative impairment rating under the direct estimate method. So if you opined that an examinee had lost 50% of the function of the upper extremity, we know that the maximum value for the upper extremity is 60% whole person. So 50% times 60% is 30% whole person impairment. So an examinee who has lost 50% of the function of the upper extremity results in a whole person impairment rating of 30%. Okay, so that's the direct estimate method as relates to the upper extremity. Your challenge is going to be in supporting your estimate approximation of loss of function. So you might ask yourself, what type of data, what type of exam findings, what type of symptoms, and what types of losses of functions of activities of daily living would it take to support an estimate of 50% loss of function of the upper extremity? Similarly, with regards to the lower extremity impairment ratings under the direct estimate method are based upon table 1732, again related to impairment values due to amputations. So with regards to the lower extremity, an examinee who has had his entire lower extremity amputated at the hip qualifies for 100% loss of function of the lower extremity. And that makes sense because there's no lower extremity left to function. So your job is to determine a percentage of loss of function of the lower extremity and then multiply that percentage loss of function by the maximum whole person impairment rating for the lower extremity, which is 40. Multiply the two to come up with an alternative impairment rating under the direct estimate method. So for example, if you opined that an examinee had 50% loss of function of the lower extremity, you would take 50%, multiply it by the maximum whole person impairment value, which is 40%, to come up with 20% whole person impairment. Again, your challenge is going to be in supporting your opinion for 50% loss of function. And we're going to see a couple of cases wherein the evaluator was unable to support that estimate with an opinion that qualified as substantial medical evidence. So with that as our background, let's review 3 cases, 2 of which represent strikeout opinions, meaning that the qualified medical evaluator was unable to provide an alternative impairment rating that qualified as substantial medical evidence. And then we have one example which represents a permanent impairment home run, where the qualified medical evaluator was able to substantially increase the permanent impairment rating because his opinion was accepted by the trier of fact as a substantial opinion. Okay, so first let's talk about the strikeouts and go into the Moten versus City of Los Angeles case. So the Moten case, this is a fairly recent case from September 2015. With the Moten case, the workers' compensation judge found permanent disability of both the lumbar spine and the left hip, and the workers' compensation judge approved a 19% permanent disability rating for those 2 body parts. Now, as we're going to see, this impairment opinion, or both impairment opinions, meaning the impairment opinion under the strict application of the AMA guides and the alternative impairment rating under Alvarez and Guzman, were both found to be defective and faulty and did not qualify as substantial medical evidence. Remember, each of your opinions on permanent impairment must in and of themselves qualify as substantial medical evidence. And then in addition, using our 4-part formula, you must explain why the strict application is not an accurate description of the examinee's impairment and why the alternative impairment rating is the most accurate description. But the 4-step procedure begins with substantial opinions first on the strict rating, and number 2 on the alternative impairment rating. And in this case, the qualified medical evaluator was unable to do either. So in this case, both the applicant and the defense appealed the case. And you can imagine that the applicant attorney appealed because the applicant attorney felt that the impairment rating was too low. And the defense appealed because the defense felt that the impairment rating, of course, was too high. So the applicant contested the workers' compensation judge's rejection of the higher alternative Alvarez-Guzman rating, and the defense contested that not only was the Alvarez-Guzman rating not substantial medical evidence, that even the impairment rating offered under the strict application of the AMA guides was incorrect, was faulty, and did not qualify as substantial medical evidence. So let's go into some of the facts of this case. Ms. Moulton was employed by the defendant, which was, I believe, the City of Los Angeles. as a police officer from 1999 to June 2012, and she suffered a cumulative injury to her low back and left hip through the end of her employment. She was examined by the agreed medical evaluator, who authored a total of 3 reports and was deposed by the parties. The agreed medical evaluator diagnosed the applicant with several diagnoses, mostly related to nerve issues, such as left neuralgia paresthetica, left femoral neuralgia, left inguinal region strain, left lumbar spine strain, multi-level spondylosis, and degenerative arthritis of the left hip. So it would seem that the first 4 diagnoses of neuralgia paresthetica, femoral neuralgia, inguinal region strain, and lumbar spine strain, those would be related to the injury itself and the subsequent symptoms that Ms. Moten has suffered, whereas multi-level spondylosis and degenerative arthritis seem to represent imaging findings. In his ratings report, Dr. AME assigned 2% whole person impairment to the applicant's low back solely as a pain rating, 2% to applicant's left hip based on loss of range of motion, 1% for left thigh muscle atrophy, and 1% for pain. So this represents a permanent impairment rating under the strict application of the AMA guides for the lumbar spine and the left hip of 6% whole person. Okay? So, of course, the applicant attorney requested an opinion on whether or not an alternative impairment rating could be perhaps a more accurate rating. And the parties deposed the AME. And the AME at deposition testified that applicant had lost 20% of the function of our lumbar spine. Thus, he changed his impairment rating of the lumbar spine from 2% to 20%, a tenfold increase, an increase of 18 percentage points of permanent impairment. So this is simply based upon the request of the applicant attorney for an alternative impairment rating. Now, the difficulty comes in explaining why, in his opinion, the examinee had lost 20% of the function of the lumbar spine. So, of course, the defense is going to ask the agreed medical evaluator to support his opinion for a 20% loss of function of the spine. So in explaining his opinion or his reasoning, the agreed medical evaluator said the following. He said, number 1, if you look at the actual MRI, she does have degenerative changes. She has bulges rated as mild bulges and some minimal bulges. So those are, in your opinion, is that a reason for increasing the impairment rating from 2% to 20%? See, here the doctor cites facts that she has some bulges rated as mild bulges and some bulges rated as minimal bulges. Does that provide a reason for increasing the impairment rating tenfold? In my opinion, it does not. He's simply citing facts related to the imaging studies. He then goes on and he says, I'd have to go back and read it, and I think that Dr. Kim, when he saw her, felt that the work restrictions were, no sitting, and prolonged standing, lifting 20 and then 25 pounds respectively. I think that would kind of be a preclusion. Let me just go to the first report. So here he describes some of the work restrictions that have been described in other evaluating physicians' reports. So these, again, are facts which are not the same as reasons. You see, reasons must be based on facts, but not all facts constitute reasons. So here the doctor is citing some facts, but they aren't reasons in support of his opinion for multiplying the impairment rating by 10. So he says, so I think when we look at her ability to function, I think that 20% loss, I think, is reasonable. So that's why I think that the 20% for the regional impairment is reasonable. And in this paragraph, in explaining his reasoning, the doctor gives absolutely no reasons whatsoever to support his opinion for increasing the impairment rating 18 percentage points, effectively increasing the impairment rating by tenfold. The reasoning in support of that opinion is actually no reasoning. So then in deposition, the agreed medical evaluator further confused and confounded the issue by assigning a new 4% whole person impairment for the femoral and lateral femoral cutaneous nerves, whereas before he provided permanent impairment only due to loss of range of motion and due to atrophy of the left thigh. So here in deposition, under the urging of the applicant attorney, the agreed medical evaluator is increasing the left hip impairment. And he opined that, in his opinion, the 20% rating for the lower back was the most accurate rating compared to the prior 2% rating under the strict application of the AMA guides. So the workers' compensation judge issued rating instructions, instructing the rater to issue a rating based on the AME's report and the AME's addition of a peripheral nerve rating in deposition. The workers' compensation judge instructed the rater to ignore the 20% rating to the applicant's lower back, opining only for the 2% impairment rating provided under the strict application of the AMA guides. Well, it got confusing because the rater noted a mathematical error in the rating for left thigh atrophy, which the rater corrected to 2%. Additionally, the rater corrected the rating to the peripheral nerves to 2% and issued the final rating, 19% whole person impairment. Okay, so this is the first rating offered by the workers' compensation judge. Well, on June 4th, the applicant objected to the rating instructions and the rating and reserved her right to cross-examine the rater after seeking reconsideration. And on June 10th, the workers' compensation judge issued a findings and award, which awarded applicant 19% permanent disability rating. Well, of course, this case went to appeal because, as we stated earlier, both the applicant attorney and the defense attorney objected to the impairment rating, with the applicant attorney objecting to the workers' compensation judge ignorance or ignoring the alternative impairment rating for 20% for the lower back, and the defense attorney objecting to both the strict application of the AMA guides rating and the alternative impairment rating. And the conclusion of the appeals board is that both the AME's strict AMA guides rating and his alternative impairment rating are defective and do not constitute substantial medical evidence. Without substantial evidence supporting applicant's permanent disability rating, we must rescind the findings as to the permanent disability level and return the matter for further development of the record. Defendant argues that the permanent disability rating should not include a rating to the applicant's left knee, and that the rater improperly combined ratings for applicant's loss of range of motion to the hip with muscle atrophy, which should not be combined, of course, according to the cross-usage chart in Chapter 17. The rating string provided by the rater notes a rating to the applicant's left knee. However, it's clear from examining the record that this was actually the rating for atrophy to applicant's left thigh with the 1% pain add-on. And then in Chapter 17, it tells us that atrophy ratings should not be combined with any of the other three possible ratings of diminished muscle function, which is gait derangement, muscle weakness, and atrophy. Peripheral nerve injury. So atrophy is not to be combined with peripheral nerve injury. Thus, it was error to combine applicants' muscle atrophy and peripheral nerve injury into the same rating. Further, the AME never completed a proper analysis of applicants' peripheral nerve injury, and it goes into the whole description as to how impairment values for sensory and motor deficits are calculated. So, therefore, the AME's opinion on peripheral nerve impairment is not substantial medical evidence. Without a substantial opinion regarding applicant's disability, we cannot affirm the judge's assignment of 19% permanent disability. And remember, the 19% was composed of the agreed medical evaluator's initial impairment rating combined with an additional 4% for peripheral nerve injury, which they pulled out of, the applicant attorney pulled out of the agreed medical evaluator in deposition, but it was found that the agreed medical evaluator simply pulled that 4% out of thin air and did not do the proper analysis of the peripheral nerve injury. So that portion of the strict or initial impairment rating was found to be insubstantial. And then finally, with regards to the alternative impairment rating for 20% whole person impairment for the lumbar spine, the appeals board stated that we find that the AME's opinion regarding an alternative impairment rating is not substantial evidence. The AME did not properly analogize applicants' lifting restrictions to the loss of use of her entire lumbar spine. So, as we stated earlier, you're going to find a challenge when it comes to providing support for your opinion of a certain percent of loss of function of the lumbar spine, and this AME was not able to do it. And for this reason, we cannot assign a permanent disability rating based on the AME's offering of an alternative Almarez and Guzman rating. So again, when using the direct estimate method, in this case sort of illustrates some errors in both the strict and in the alternative impairment analysis. But when using the direct estimate method, your challenge is going to be in supporting your percentage of loss of function of the region of the body, whether that be the spine, the upper extremity, or the lower extremity. Now, in another case, the Porter versus Riddy home care case, again, the alternative impairment rating using the direct estimate method was found to be insubstantial. So, under the strict application of the AMA guides, the workers' compensation judge found 8% whole person impairment under the DRE method, plus a 3% add-on for pain, for a total of 11% whole person impairment for the cervical spine. The workers' compensation judge rejected the QME's alternative impairment rating under the direct estimate method as not substantial evidence. And if I was the defense attorney in this case, I might have even objected to the 11% whole person impairment rating as including a duplicative 3% add-on. It seems that in coming up with the whole 8% whole person impairment rating, that would include the 5 plus 3% under the DRE Category 2 method. So perhaps this additional 3% add-on is duplicative, and perhaps the defense attorney could have raised this as an objection as well. So let's review the DRE Cervical Category 2. So the DRE Cervical Category 2 tells us that the examinee has a history and examination findings that are compatible with a specific injury. So this is one of the DRE categories that you can use in those cases that involve a specific injury. This is not to be used in those cases that involve a cumulative or repetitive stress injury, but rather is reserved for those cases that involve a specific injury. Also, the physical examination findings at the time of evaluation include one or more of the following: muscle guarding or muscle spasm, asymmetric loss of range of motion, or non-verifiable radiculopathy. In the alternative, this could also qualify for an examinee who had a clinically significant radiculopathy and an imaging study that demonstrated a herniated disc at the level and on the side that would be expected based on the radiculopathy, but has improved following non-operative treatment. And this qualifies for 5 to 8% impairment of the whole person. Now, you as the evaluating physician have the discretion to employ a permanent impairment rating within the range of 5 to 8%. Typically, we would think of this type of an examinee as qualifying for 5% whole person. But in extenuating circumstances and when supported by multiple and voluminous reasons, you can opine for 6%. You can opine for 7%. You can opine for the maximum 8% value when the facts of the case justify a higher impairment rating within the range. Now, typically, we consider the 8% to be comprised of the 5% plus a 3% additional discretionary add-on due to an extremely adverse impact of this condition upon the examinee's activities of daily living. So we know that examinees who have a 5% impairment of the cervical spine, they're going to have symptoms. They're going to have limitations with activities of daily living. But if those symptoms and if those limitations and activities of daily living are above and beyond what you would consider to be expected for someone with this condition, you can employ a 3% discretionary add-on to bring the impairment rating to the maximum value of 8% whole person. Well, in this case, the medical evaluator opined for the highest value within the range at 8% and then added an additional 3% as a pain additional add-on. So that might be a source of possible objection for the defense attorney by citing that the additional 3% discretionary add-on has been added twice. Okay, so let's see what the judge had to say about this. So in this case, the workers' compensation judge correctly rejected the Alvarez and Guzman analysis, which we'll go into a minute, and rather deferred to the 11% under the strict application of the AMA guides. So in describing his use of an alternative impairment rating, the medical evaluator stated that this case is felt to be complex and extraordinary because the patient's pain and symptomatology are greater than what one would find related to a simple and straightforward diagnosis. Now, here the doctor does not explain why it's complex and extraordinary. He does not explain what the patient's pain and symptomatology are greater than what one would find related to a simple and straightforward diagnosis. And this is not supported with how and why reasoning. Why is the patient's pain greater than what would be related to a straightforward diagnosis? Why is the patient's examinee and what examples of the patient's symptomatology are greater than what would be expected with a straightforward diagnosis? So this does not have any support. He then goes on and he says, it's my opinion that the strict whole person impairment rating would not be an accurate measurement of this patient's permanent impairment based on my clinical experience and in consideration of the effects of the residuals of the work injury on the patient's activities of daily living. Now, let me admonish you evaluators, do not use this phrase. This is not a supporting phrase based on my clinical experience. Why is your clinical experience such that it's your opinion that this is not an accurate measurement? This does not explain how, it does not explain why, and I'm going to encourage you not to use this as a supportive reason for any of your opinions and conclusions. He then goes on and he says, and in consideration of the effects of the residuals of the work injuries on the patient's activities of daily living. And here he does not describe which activities of daily living are so adversely affected by the examinee's symptoms. He says, therefore, in this case, the patient would fall into a group of patients whose level of whole person impairment is greater than that obtained using a strict interpretation of the AMA Guides to the Evaluation of Disability, 5th edition. And he gives no reasons in support of why the examinee qualifies for an alternative impairment rating. Well, he tries to, though. He tries to justify his use of the direct estimate method by stating that it should be acknowledged that the lumbar spine has two different primary functions. The first is a levering function in which the back is utilized to lift, stoop, bend, and carry objects placed outside the center of gravity of the body. The second lumbar spine function is of support, in which the upper body, head, and upper extremities are supported while the individual is in a weight-bearing position, such as standing and walking. In considering these functions in combination, such as meaning levering and support, it is my reasonable medical opinion, to a degree of medical probability, that the patient exhibits a 20% loss of function of the lumbar spine. And here he gives no reasoning to support why 20%, why not 15%, why not 50%. What is it about the examinee's loss of levering and loss of support function that qualifies for a 20% loss of function? He then does the math and he says, pursuant to figure 19, this equates to 18% whole person impairment. So with this alternative impairment rating, the evaluator increases the impairment rating from 11% whole person impairment to here 18% whole person impairment, a near doubling of the whole person impairment. And he justifies his reasoning for an 18% whole person impairment based upon his experience in managing and evaluating similar to same cases. And actually, within the body of this argument, there is not one good, substantial reason to support an alternative impairment rating. Well, of course, he was deposed in January 2016, and he said, in explaining his rating, he says, and you're talking about someone being dislocated from their job, and you're going to give her an 8%, it doesn't add up. So he justifies his increase of the alternative impairment rating from 8% under the DRE method to 18% by citing that she's been displaced from her job. Now, is that a medical reason? Is that based on physical examination findings? Is that based upon anything clinically significant? It's not. It's simply based on the fact that, in his opinion, because she's been dislocated from her job, she qualifies for a higher impairment rating. And he says, and her clinical presentation does not add up either. But he doesn't state what about her clinical presentation doesn't add up. He says, and then I'm not allowed because of the AMA guides to give her 3% for pain. It's disallowed. So it seems that the defense attorney did object to the additional 3% discretionary add-on. He says, so I can't mix that with the 8%. At a later deposition, Dr. Shaw was asked, why is it that Miss Porter, for her lumbar spine, could not fit into the DRE for her lumbar spine? And Dr. Shaw responded, well, from a strict standpoint, she can, but from a Guzman standpoint, where you're actually evaluating someone for their functional loss, it does not match up. Well, the workers' compensation judge was not convinced by this opinion, and as she explained in her opinion on decision, she said that the AME's opinion is not a proper rebuttal of the scheduled rating in the guides. She explained that in order to support the case for rebuttal, the physician must, number one, explain why a departure from the impairment percentages is necessary and how he or she arrived at a different rating. Here, Dr. Shaw does not adequately explain his conclusion that a strict application of the AMA guides does not accurately reflect the applicant's impairment. In fact, he said in his second deposition that the DRE method did accurately reflect the applicant's impairment, or why a strict application of the AMA guides is not warranted because of the peculiarities of this particular case. Additionally, it appears that doctor's alternative analysis was based on the incorrect assumption that a pain add-on is not allowed within the DRE method. And finally, and this is important because this refers back to some of the confusion that we discussed related to figure 1519 and the direct estimate method, she stated that figure 1519 of the AMA guides is not a table or a method. Remember, Alvarez and Guzman allows us to use additional chapters, additional tables, or additional rating methods within the four corners of the guides, but here figure 1519 provides information on how to convert a whole person impairment to a regional estimate of spinal impairment. It is not intended to be used as a rating mechanism, and neither the applicant nor the AME specify where the rating method utilized, which was multiplying his assessment of the percentage loss of function of the body part by the body part's maximum impairment for the cervical spine, is outlined in the AMA guides. So here case law is clear that figure 1519 is not a rating method. It's simply a diagram that shows how to convert whole person impairment to a regional estimate of spinal impairment, which in my career I've never once been asked to provide. So that opinion was found to be insubstantial. Well, finally, we have a home run case wherein the qualified medical evaluator was able to opine for a higher alternative impairment rating, and the rating was upheld eventually by the appeals board. Even though the workers' compensation judge initially denied the alternative impairment rating, the appeals board found the AME's opinion to be substantial and increased the initial impairment rating of 29% whole person impairment to 45% whole person impairment for the lumbar spine. So let's briefly review this case. So under the range of motion method, the doctor concluded that the applicant had 29% whole person impairment, but he then stated that, in my opinion, the lumbar impairment is underrepresented by a strict use of the AMA guides. Now, he does not explain why. He does not explain why it's underrepresented. He just says, in my opinion. An alternative manner of arriving at his impairment, still within the four corners of the guides, by analogy, would be to consider the spine as a whole and to calculate whole person impairment as an appropriate fraction of the whole, taking all things into consideration, including the patient's history, and he's not specific as to what aspects of the patient's history. He's not specific as to what aspects of the clinical presentation. He's not specific as to what entries in the medical records are significant. He's not specific as to any overall decrease in level of function. And in his mid-range responses to certain questionnaires and all this stuff, it is my opinion, taking all this stuff into consideration, that Mr. Espinosa's impairment is more accurately described as a 50% decrease in his overall lumbar of function, which qualifies as 45% whole person impairment. So here he offers no actual reasons to support his use of an alternative impairment rating. Well, of course, he was deposed, and he explained, and he tried to support his opinion that the applicant had a 50% decrease in his function based on his performance on physical examination, as well as the level of discomfort he has, and the described subjective impact that his injury and his level of pain has on his activities of daily living. He took those three considerations as a whole in escalating the impairment rating from 29% to 45%, an increase in the impairment rating of 16 percentage points. He doesn't describe what aspects of the physical exam support this increase. He doesn't support what level of discomfort supports this increase. And further, the loss of function for activities of daily living are simply those that have been described to him by the examinee, which of course are subjective only. So this represents what I would consider to be a weak reasoning in support of an alternative impairment rating. And then when asked about how he reached his conclusion that there's a 45% whole person impairment, the doctor testified that he simply did the mathematics as described in figure 1519. He describes the mathematics behind the derivation of the 45%, but he does not explain his reasoning as to how he came up with the 50% loss of function. So the defendant, of course, objected to this alternative impairment rating, but the appeals board found that the doctor somehow had supported his alternative impairment opinion. And they explained their position by saying that here the evaluator examined the applicant on 3 occasions. He reviewed his extensive medical record and he assigned a whole person impairment rating using a strict application of the guides. That's part 1 of our formula. He then exercised his clinical judgment and reached his conclusion that the strict application of the guides did not accurately describe the applicant's disability. In his report and deposition testimony, the doctor explained why his use of the regional spine impairment was a more accurate description of applicant's impairment. Also, as the AME, Dr. was presumably chosen by the parties because of his expertise and neutrality. Therefore, his opinion should ordinarily be followed unless there is good reason to find the opinion unpersuasive. The record contains no evidence that warrants a finding that the evaluator's opinion are unpersuasive. Thus, his opinion that applicant had 45% whole person impairment regarding his lumbar spine constitutes substantial evidence, and therefore the applicant was awarded 45% whole person impairment for the lumbar spine. So, in my opinion, this case represents an anomaly wherein the direct estimate method for the spine was upheld by the Court of Appeal. And even though, in my opinion, unless there's information that's missing from this court document, in my opinion, the doctor did not adequately support his reasoning why, the opinion was nonetheless upheld by the Court of Appeal.
So doctors, I hope this helps you. Here's 3 cases that involve the direct estimate method of providing an opinion for an alternative permanent impairment rating. So with the direct estimate method, you simply take your estimate of the percentage of loss of function of the particular body part involved, whether that be the spine, whether it be an upper extremity or a lower extremity, and then you multiply that percentage of loss of function by the maximum impairment value for 100% loss of function of that particular body part to come up with your percentage of permanent impairment. Now, of course, the challenge under our 4-part formula is in providing support, number 1, as to why the permanent impairment rating under the strict application of the AMA guides is not accurate. That's going to be difficult because according to the law, the scheduled rating under the AMA guides is prima facie evidence of the correct rating. So you're going to have some challenge in rebutting no less an authority than the AMA guides, but it can be done. And then number 2, in supporting your opinion as to why the alternative impairment rating is the most accurate rating, of the lumbar spine. Now, we've seen cases here where, despite the evaluator's opinions and reasons in support of the opinions, the trier of fact opined that the direct estimate method, at least under figure 1519 of the AMA guides, was not a method, is not an established method for rating impairment of the spine. It's simply a method for converting whole person impairment to a regional spine impairment. And we saw another case where the appeals board upheld the direct estimate method directly based upon figure 1519. So we have case law example for opinions on both sides of the direct estimate method, at least as relates to the spine. So I believe that a precedent has been set that you can use the direct estimate method for the spine, the upper extremity, and the lower extremity, especially if your reasons in support of your estimate of loss of function of the body part are substantial, are voluminous, and are compelling, and are based on verifiable facts in the medical record, in the physical examination, and perhaps even in functional capacity evaluation. Again, the value of your alternative impairment rating rests upon your reasons in support of your opinion. So doctors, I hope this helps you, and I hope you find some applications for the use of the direct estimate methods in some of your upcoming cases. So in our next session, we're going to talk about permanent impairment ratings due to analogy to gait and gait disturbance. So I look forward to being with you on our very next session. For now, this is Dr. Perry Carpenter wishing you best of success in your career as a qualified medical